Okay, so I'm going to introduce our fabulous panel of experts here. First, we have Dr. John Olichney. Dr. Olichney is the professor of neurology at UC Davis. He is a behavioral neurologist and behavioral scientist for the Department of Neurology. He is the director of the California Alzheimer's Disease Center in Walnut Creek and clinical core director of the Alzheimer's Disease Center for the National Institute on Aging at UC Davis. Welcome, Dr. Olichney. Next, we have Dr. Rita Hargrave, who is a board-certified geriatric psychiatrist at the Veterans Administration Martinez Outpatient Mental Health Clinic and consulting psychiatrist at the University of California, Davis Alzheimer's Disease Center. She's a clinical instructor in the Department of Psychiatry at University of California, Davis. She's the chair of the American Board of Psychiatry and Neurology Committee on Geriatric Psychiatry Certification. She has a prolific contribution to journals, magazines, and books exploring neuropsychiatry, cross-cultural psychiatry, and ethnic minority caregivers. She's also founded ethnicelderscare.net, a website focused on ethnicity and dementia. Ladies and gentlemen, Dr. Hargrave. And we are also joined by your two morning speakers, Dr. Woods and Heather Gray. We're so excited to have them back to answer our questions. So we have a lot of questions to get to, but I'm going to start us off with a softball, and I'm going to direct this to Dr. Hargrave, because I know this came up in the morning session, and it keeps coming up, and it's probably the question that I get asked the most. So Dr. Hargrave, I'm going to ask you to tell us the difference between Alzheimer's disease and dementia, so that we have that good clarity for our discussion this morning.
Okay, you're right. That's a very important and very common question because people use them interchangeably. If you think about, we're thinking about this. If you think about music, for instance, so music is a really big term, but you've got R&B, you have jazz, you have Afro-Cuban, and that's sort of the way you can look at dementia. Dementia is the big umbrella, and a little sideline, especially within that, is Alzheimer's disease. Because now that we've gotten so much research over the years, we realize that there are many types of dementia. So Alzheimer's is the most common, but it's one of many forms of dementia.
Great, thank you. We've had some themes and questions, so I'm going to try and pull them all together here. But sort of going a little bit to some of the basics of the science. Dr. Olichney, I'm going to ask you the question about hereditary. Is Alzheimer's disease hereditary?
Well, in the last 20 years, the answer has increasingly been yes, but still, let's put that in context, age is the number one risk factor. So dementia and Alzheimer's doubles every 5 years after 65. So age is still number one, but it runs somewhat in families, and major genetic risk is ApoE4. Is that a separate question?
Yeah, so then I was going to follow up that one. So you could go ahead with that about the blood tests around the ApoE4.
So the most common gene that's associated with Alzheimer's disease is something called apolipoprotein E4. And it was first described in the cardiac literature, something caused premature hardening of the arteries in heart disease. And in the 1990s, we discovered it was a very important risk factor for Alzheimer's disease. You get one of the copies of this gene for your mother and one for your father. If you have the bad luck of getting the ApoE4 genotype on both of those alleles, that increases your risk of dementia and Alzheimer's with a lot of amyloid plaques by 9 or 10-fold. Now, if you have one copy, which is more common, that would be about a 2 to 3-fold increased risk of Alzheimer's dementia. So that's a major risk factor, and it often has a comorbidity of heart disease and perhaps vascular disease and strokes as well. So that's part of the explanation why so often Alzheimer's disease and small infarcts can coexist. ApoE4 is a cholesterol carrier in the blood, but it relates to clearing amyloid plaques from the brain.
And so the question about, are we generally testing for those genetic components?
At our research center, we do that as the rule. Pretty much every participant who's donated blood, we have obtained ApoE4 genotype because it's an important risk factor. But in clinical practice, it's been decided that it really wasn't cost effective to send for that gene. As in, if someone has probable Alzheimer's disease, there's about an 85% chance that that diagnosis is correct. And if you have the E4, it might help the doctor know that's the most likely etiology for why a person has Alzheimer's disease. But it doesn't yet suggest any different treatment than Alzheimer's disease patients that don't have that gene. So it really doesn't have implication for how we treat the patient yet. And if you don't have that gene, it doesn't mean that you don't have Alzheimer's, because it might account for 40% of Alzheimer's disease in our country. So the other 60% would still have a negative test. So it doesn't help our diagnostic accuracy significantly. Careful research showed it was a 2% increase, 85 to 87%, and that was very little. So it was not thought to be cost effective, particularly enlightening for whether somebody has Alzheimer's disease or not.
Great, thank you. Dr. Woods, I'm going to ask you to start with the next one, but I should say to our panel, jump in on any of these. Because we get this question a lot about the benefits of including or not including someone living with Alzheimer's disease or a related disorder in decision making. And we know that in the early stages that's a good thing, but there's always that potential for when is it not a good time. So what's your advice to people who are looking as to when they should include their loved one in those decisions?
So I usually, can you hear me? Yeah. I usually have people included in those decisions all the time until it is obvious that they cannot. But there will be an entire spectrum of time where that person can be involved in the conversation, but that their family member or decision maker or advocate should always be there with them. Because in that moment, someone can have an understanding of the conversation and can very clearly express what their wishes are, but they may not remember that conversation the next day. They may not remember that conversation as they're leaving the office. So I always suggest that the person is there unless there's a reason for them not to be.
Great, thank you. So Heather, thank you for joining us on the panel. We had a lot of questions as a follow-up from your presentation this morning, not surprising. Here's one that I think is a really good one that a lot of families get questions about is, when you have someone living at home with a disease who you know then is getting to that point of not being safe anymore in their home environment. But if I were to ask you, Dr. Hargrave, to move to a nursing home with me tomorrow, I'm sure you're going to say no, right? What's your advice to families that are dealing with someone that has to be placed who don't want to go?
So who would want to live in a nursing home? Nobody, right? So, Rita. I would like to look at this new place with you. They have gardening, they have all these activities, they have pets, kids come over. Can you go with me tomorrow? All right, so that would be perfect if that worked all the time, but it doesn't, right? That you can, if you're not able to have those, I'm sorry, Stephanie. If you're not able to have those conversations ahead of time so that you know your loved one's wishes, oftentimes you have to just do it, right? You have to investigate, you have to bring all of their items over so you make the room look like their own room, and then you acclimate them to the facility. Prepping them ahead of time. We're going next week. Rita's going to hit me and yell at me and like, I'm not going anywhere, this is my home, right? That's not going to work. But if you prep ahead of time, right, if you have the space, you know the facility, you trust the people, that when it's ready to make the move, you make the move, right? That day, that weekend. Prepping them and telling them a month in advance is not going to do you any good. That would be my suggestion as far as if you're going to have somebody difficult. If the person is able to go, right, is able to make that decision, then I would go with them, have them come with me so that they can see the thing. So you kind of have two ways, one extreme and the other extreme.
And I want to add to that prepping the staff of where they're going to go is also an important piece of it. Because I've found that if staff has an ongoing working relationship with family members and they feel comfortable calling family members about what is this person's needs, what kind of food do they like, what sort of things do they like in terms of how they take care of their personal hygiene, what sort of activities. So because everybody who comes into those settings is different. Now, the daughter will know after, however many years, 50 years, what mom likes and doesn't like. The whole staff will have no clue. So if you can find a person in that staff who you feel comfortable with, to have some regular contact with and prep them, that will make the transition, again, even easier. So keeping that dialogue open with staff.
So can I just unplug in FCA? So
Yes.
So FCA has a great checklist. I call it the Barbie Dreamhouse wish list. And it basically has everything that you want for your loved one. And also is good, it also gives like a good summary of what your mother likes or dislikes so that the staff knows. What you don't want to happen is just to dump the person off and not communicate with the staff. Right? Because that transition is not going to work for them. What you want to be able to prepare them. Dr. Woods? Family Caregiver Alliance? Joe, raise your hand, Joe.
There's Joe.
In the back.
So our next question would be for any one of our docs here to answer. How do you know when your patient is experiencing real pain? What signs should a family member be looking for that they're really in pain? I'm assuming when they're not able to tell you, I'm in pain.
I guess everybody, we probably get two different versions of this, but what I usually hear has to do with changes in behavior, sleep, appetite, and level of activity. People who look uncomfortable, they pace more, they may be up at night, unable to sleep, they look uncomfortable, they may just be more grouchy and not be willing to let somebody help them with their personal needs, with showers and whatnot. So it's a real change in behavior. Again, it sort of depends on the person. I seldom have folks who are pretty far advanced with dementia who I can ask, how bad is your pain? Most of them cannot really quantify that in a reliable way. But family members who have observed changes in behaviors are probably much more reliable about that.
I would add crying or sweating. I know. Crying or sweating are also really nice signs that someone is in pain. And we also, like in the office, use heart rate if it's elevated. May also be an indication that someone is in pain.
So I want to talk for a little bit. We had this question during your session, Heather. We didn't get to it. And do you have those suggestions for the person who is constantly asking to go home? They're not mobile, so things like being able to take them somewhere, and it just goes on for hours. I want to go home. I want to go home. I want to go home.
Thanks for that question.
Oh, you're welcome.
Redirection will be your best friend. Redirection, stimulating them with a different activity, getting them fixated on something else other than I want to go home. I kind of talked about this earlier. We don't know what that means because we don't know what home is, right? Clearly, it's not where they're at right now, right? So making them feel comfortable, addressing the anxiety, because that's probably what the emotional core that the person's feeling is: anxiety, uncertainty, frustration. So if we're able to address that emotional need, then we'll be able to redirect them to something else that doesn't cause them that distress.
And around the same sort of subject, and again, for any one of you to answer, that brings up a lot of feelings for caregivers about frustration, guilt. Guilt was one thing that came up in a couple of the questions here, is that feeling about guilt, whether it's over taking advantage of respite options, or I get a lot of questions from families who feel guilty for what you just described could be interpreted as lying to mom. So how should families approach those frustration levels and that feeling of guilt?
I guess was recommended before, and I think it's always a good idea to not be the only person in the room who is dealing with these challenges. Because so often, no matter how many brothers and sisters there are, there's going to be one person who is carrying that entire load. Now, with a lot of our women, they say, this is what I need to do. This is who I am. I'm the oldest daughter. I'm the one who's supposed to do this. But nobody said you had to do it alone. So to be able to share some of that frustration, some of that guilt, because it's going to be there. There's no way around it. To be able to share that with other people, to have a distraction or an outlet when it's up to here, I think is invaluable. And also having other people in your network, be it church members, family members, who can take care of some of those responsibilities with you, so you don't feel like you're alone. And finally, the support groups, to find out how other people navigate these same phases of adjustment to your new life as a full-time caregiver.
Ditto. Okay, good. All right, so then let's talk about the magical word driving. Oh boy, the audience has just turned on me. Any strategies for dealing for someone who is no longer able to drive but wants to?
Break the car! So, I guess I'm responding. So, I like to think of this as somebody's going to have to take those car keys out of my hand when I'm dead, right? This is probably one of the toughest decisions after making the decision to go get a diagnosis or go see a doctor that you'll have to make. The first toughest decision. It's really, no offense, physicians, put the blame on the physician. Put the blame someplace else, right? The doctor told you, I'm serious, this is what they tell me, surprise.
If it was up to me, Heather, you would be able to drive as long as you wanted to. But Dr. Olichney told me you can't do it anymore.
I hate him, right? But if you place the blame on somebody else, and really, in California, the doctors are supposed to report the diagnosis to DMV. It's not really up to the doctors, it's up to DMV, right? Are they going to administer the test? When are they going to call the person in? So it's not really up to you. So it's not a lie, it's not a biblet. Well, it's a biblet, but it's not a lie. But, this is about safety. Disable the car, right? Make the car disappear, right? It's at the mechanic, your grandson has it, right? It's somebody else's fault, right? Because everything else will be your fault later.
It needs to defend itself.
Defend yourself.
A bad cop rebuttal. I would go back to Dr. Hargrave's point that really no one should take this on alone, including the bad cop doctor. When somebody is very severely impaired and it's clear they don't have any business in a car and they don't really even know the mechanics, it's pretty obvious. And then these ways of just taking the access out of the environment is the appropriate and necessary thing. But there also are patients that are very mild, and to distribute the decision, I tell patients we're required by California law when we diagnose Alzheimer's or other dementia, we must report, and then DMV is supposed to do diligence and offer testing for cases where it's reasonable, where someone might be a candidate for a limited license. The trends in recent years has been to get less road tests, and it's been a little bit discouraging. I think it's hard for patients to get a road test for a limited license. But when that happens, and at the appropriate stage they fail that road test, that supports the family and the caregiver, and it supports the doctor too, and say, well, I don't think it's safe for you to drive. I have serious concerns. Sometimes I tell them just what's necessary for survival when they're in a very mild stage, and I give them driving precautions as I report them. But I don't necessarily, by reporting, we don't have to take away someone's license if they're at a very mild stage where they just have short-term memory loss and they hardly have effects in other cognitive activities. So there's a whole spectrum of severity here. And so being a partner in that. Yeah, but I am the bad cop. We're required to report it. When we think it's dangerous, we have to make that decision. But it's sometimes gray. It's not always black and white.
Can I just add one thing about the driving? I think it's really important for you to remember that driving is not about remembering how to get from A to B, right? It's not, they know how to get home, or they know how to get to the grocery store, it does take all capacities of cognition, right? So organizational skills, perception, that could be impacted by the disease. So working with your doctor is extremely important about figuring out what capacity does my loved one have to be able to drive, to perform those tasks.
Dr. Woods.
I just wanted to add that that's a conversation I have in the office all the time, and that it's not about the mechanics of driving. That person's probably been driving longer than anybody in the room, but their ability to react when something unexpected happens, or if they're on a road in an unfamiliar area. It's all of these cognitive areas. It's not just the mechanics of driving. And I often tell families, if they feel comfortable having that person drive grandkids that are 5 or younger in the car by themselves, I want to know about it. But if they're not, then it may be time to have a conversation about stopping driving.
So we have about 30 seconds left, and I'm getting a high sign from Craig, but I have 2 questions. I'm going to do at least one of them and see how we are in time, because they're really important ones. And I do have a stack of other questions, and at the Alzheimer's Association, we're going to take a look at these and see if maybe we can't do FAQ blog post or something, and work with our communications team to do something to get the rest of these answered. But this one's about bathing, and I think this is another hot topic for families. Why won't they bathe? And then any tips for how we can get people into the shower?
When you think about it, when was the last time another grown-up helped you take your clothes off and put things on you?
Let's not answer that question.
Really? No, I was trying to get to the end. But where am I going with this? It's kind of embarrassing and it's kind of scary. I mean, because nobody's done that to me for many, many years. So if that's something that most grown-ups would have some difficulty with, even with all their cognitive faculties intact, can you imagine what it's like when your memory's not good and you may not see as well, and your mind is going a little slowly? So it's kind of scary. So my sense is, how often do you really need to bathe? I mean, full body showers, full baths, does that have to happen every day? Can a little wet wipes, will that do? A couple of times a week? Brushing teeth. So I think making some adjustments in what your expectation of how often those ADLs are being carried out is also part of this negotiation that you're making, and recognizing that it is kind of scary, and that many people have, if it's someone of a different gender, trying to bathe your father, that adds another level of concern. So I think there's many things that are factored into why bathing is a challenge.
So I have many patients that don't want to bathe or are resistant to bathing, but they'll bathe when they know they have to go to the doctor's office. And so their family members, often to get them to bathe, even if it's once a week, they tell them they have a doctor's appointment. And then they'll say the doctor canceled the appointment. I also have a family where their dad loves this one restaurant. He loves to eat there, but he will not bathe, and he'll go weeks at a time not bathing, but he wants to go to the restaurant. So they say, this restaurant won't let you in unless you bathe first. And so then he'll take a bath, and then he'll go to the restaurant.
Whatever works, right? Go with the flow. Well, I'm so sorry that we didn't have enough time. I actually said to Edie and Craig this morning, I was worried that we wouldn't get any questions. But I want to thank our esteemed panel of experts. Thank you so much for sharing your time. We're going to hear from Dr. Olichney a little bit later this afternoon.